Hi, my name's Marina Boulton, and
I'm Marcus Bicknell. Hi, I'm an OAP GP.
yeah, and I'm a foundation year 2, so I'm at the start of my career. So we're going to be running the session today on inclusive general practice, and we're going to be providing kind of a bit of an early career perspective and one from Marcus, who's had a fantastic career already in inclusion healthcare. So we're going to be talking a bit about that today. So this is what we're kind of going to be covering in the session.
Yeah, so I want you as an audience to think, what does inclusion mean to you in terms of healthcare? What does exclusion mean, the opposite? Who's excluded from healthcare? And what do we do as general practitioners to bridge that, to make things happen for these ever so special and important patients? So we're going to be defining inclusion for you. We're going to be thinking about what inequity and inequality means, how we as doctors are advocates for our patients. We're going to look at our challenges and look at the rewards that we gain from a career working with marginalised groups, disadvantaged groups. Now, we don't work for the Royal Navy, and we have never met before this morning. It just happens that we have the same fashion sense, which is Zara, by the way. Next slide, please.
Fantastic. And I think just before we move on, it would be great just to get an idea of who's in the room, because we're quite a nice small group. So just a raise of hands for people in training. Yeah. Or sort of in med school or in sort of early years of their career, and then to GPs, established sort of career. And then what about you guys? You've not put your hands up. A-level students, lovely. So in training, so perspective.
Fantastic. Thinking about careers in medicine, possibly. Wonderful, yeah. And who's from north of Birmingham? Who's working north of Birmingham at the moment? And who's working south of Birmingham at the moment? Excellent. So we've got a good split.
Brilliant.
And everyone who is not in this room at the college, but at home or elsewhere, we look forward to getting questions from you throughout the workshop, please. Thank you.
Brilliant. So to start off with, I just want to talk a little bit about advocacy. So advocacy is completely key in inclusion healthcare, and we'll go into it later. But it's all about, so it's kind of speaking up for our patients and these vulnerable populations, and within the kind of society we're living in, the political pressures, the environmental pressures, everything like that is key as a doctor working in inclusion healthcare to become an advocate as part of your role. So just to kind of get some definitions out there. So the basic definition of an advocate is someone who publicly supports or recommends a particular cause or policy. But when we're thinking about doctors and advocating as a doctor, it's a little bit more specific. So it's more about kind of promoting these larger changes from what you see in professional practice, and what you can see is sort of external factors that are impacting your patients and are a threat to their health and their well-being. So what sort of advocacy in relation to the medical workforce sort of recognises is our unique position with understanding intimately patient needs, but also having that position within society to bring about change in that respect. So it's kind of just appreciating it specifically from a medical point of view.
So you can be an advocate at an individual patient level in the consulting room or in the consultation, which is very special and powerful, and things will be shared with you or shared with us that we might not even imagine. But also you can be an advocate on a national scale or a global scale in terms of advocating for better healthcare for populations as well as for individuals, which is a great opportunity as careers evolve.
And a huge part of inclusion health that we'll move into is kind of sharing what you learn from practice to try and help on a wider level, so to try and help those populations and ultimately reduce health inequalities. So lots of educational programs and using your position and what your professional knowledge to lobby governments for financial and legislative reform. So it's just trying to think of, like Mark said, the individual level, but also wider on a population level and a system-based level as well.
So we're going to look at some of the great advocates, aren't we? Let's have
Yeah, so to start off with, we've just got, this is kind of, really quickly, just kind of what I think they talk about in medical training already in terms of advocacy. I think we hear the word quite a lot, but it's normally about autonomy and protecting patient autonomy. So stuff about trying to facilitate the best communication possible in terms of getting capacity, assessing capacity and trying to get consent. But we don't really talk about it more widely in what does it mean to be an advocate in terms of thinking about wider health needs and sort of external factors and impacts on health. So again, this is just quickly just to show, this is the only kind of imagery I was shown during medical school to do with advocacy. Does anyone recognise this painting? No. So it's called The Doctor, and it's basically meant to show a very dedicated GP at a bedside, and he's out and he's with this unwell child, and he's in the home environment, and he's taking that extra step to provide this holistic healthcare and to be there. But this talk is basically just meant to sort of think about what's beyond that picture, and actually how could that GP support outside of that home environment? What other factors are going on that he should also be involved in, and trying to help that family in improving their health needs. So stuff like sanitation, education level of the parents, do they know about good health behaviours, nutrition, stuff like that, what's available, and what outside of that could have helped prevent that child getting so unwell.
There's also a real poignancy there that you kind of get the sense that that doctor might be that patient's only hope, and that it might even be a futile situation, you know, a really poorly child perhaps with diphtheria in the 1890s, and what is invested in that doctor as the advocate and the physician by the family. It's huge, really.
And again, it's just playing back to that first slide and that idea that who's in a better position, really, who else is going to see and understand these external impacts and what's causing these poor health outcomes, and actually just that idea that maybe we do have a social responsibility as doctors to share that knowledge. So yeah, this is some, as Marcus said earlier, a bit wordy, but this is basically just pointing out again that politics and medicine actually are a lot more closely connected than we might initially realise, and actually we're in the perfect position, as it says at the bottom there, that physicians are the natural attorneys of the poor, and the social problems fall to a large extent within their jurisdiction, so actually it's kind of within our role.
And we've also got a medical quiz here for you, because this is Virchow, the famous Virchow. So just connect Virchow and his famous, do you remember what he's famous for? His lymph node, Virchow's node, Courvoisier's sign, stomach cancer. So this is the great Virchow, thinking of doctors as advocates and the natural attorneys of the poor. So he's one of the greats. Then we've got another quiz for you, just to give you the links between the clinical and the philosophical. And this is William Osler. Now, I'd forgotten what Osler's nodes are. Why did everyone always name things and call them nodes? But Marina will tell us about Osler.
So yeah, it's another it's just showing this. These ideas go back to the 19th century, and Osler developed sort of Osler's node for infective endocarditis. So we're talking about sort of nodes on the palps of the fingers.
So lots of endocarditis in you know, turn of the century Americas, and what Osler is saying is the great physician, the great doctor, the great GP treats the patient. You're not treating diseases, you're treating patients, you're treating people. And when we move on in a minute to talk about these excluded and marginalised groups, we'll hope you'll get a sense and feel for that. So this is another great, and one of the lovely things about today is it's intergenerational and cross-generational, and this is from Michael Marmot. And I'm very proud to say that Michael Marmot interviewed me in 1987 for my first degree in public health and epidemiology. He was my external examiner, Prof. Marmot. He described the J-shaped curve in alcohol, and he's one of our country's and the world's greatest advocate in how we address inequalities in health systems, how we help the poor, people who are born with very little, grow up with very little, the social determinants of health, which are absolutely massive. So I'm passionate about what Marmot says. He describes this graph, this illustration of how the individual, society, communities work, and the socioeconomics, the cultural and environmental conditions. So you think back to slum housing, you think about air quality, you think about road traffic accidents, you think about the bigger picture of how you actually help populations to be healthier. And what Marmot has clearly said just pre-COVID is that life expectancy was diminishing in this country pre-COVID because of disinvestment in healthcare services by governments. COVID obviously has ridden a coach and horses through that. So the effects on morbidity and mortality of poverty and governments unable or not willing to invest in healthcare are paramount.
And I think what Michael Marmot very has a fantastic sort of constructive view to what to do about this. So he speaks about actually the best way to do things is if we allocated these resources more evenly and we reduce these health inequities, then patients would actually have their own power to focus more on their health behaviours and make that positive change themselves. So the best thing we can do as health professionals is actually just try and facilitate patients to take those, to be in a position where they're able to act on their own intentions to try and improve their health behaviours. And I think this kind of goes back to very beautifully to this very old sort of theory. Is anybody familiar with Maslow's hierarchy of needs? So again, this is something that I was shown a lot in medical school to try and understand vulnerable populations and how they act and how they seek healthcare. So it's just this idea that if we don't provide good shelter, like good housing, food, we don't provide good childcare, then there's no way that these people can fully develop. So they can't reach their full potential for good, full lives and contribute to society. So it's just, as we were saying, this idea that if you give people the opportunity, this man Maslow was a big believer in seeing the strength in people and recognising their own individual power, and just saying that if you give people this stuff, they will naturally be able to develop. So it's just thinking about meeting people's basic needs so that actually we can give them the opportunity to live a fuller life.
So this is very much about social justice. And the next slide introduces Julian Tudor-Hart, who described the inverse care law, a GP working in the valleys of South Wales in the 1960s and 1970s, who identified that the poorest people have the greatest healthcare need, but they have the least resources, and there's the least resource provision for those people. And how wrong is that? So the inverse care law is something that is now fundamental in general practice, in our understanding of general practice. And as someone who's been a commissioner of healthcare services in Nottinghamshire, addressing the inverse care law, getting more resources to our poorest, most vulnerable, our most disadvantaged patients is key. So we look at healthy life expectancy in Nottingham, and within a mile, there can be 20 years difference. Someone in Wollerton can have 70 years of health life expectancy, and someone in Bilborough can have 50. So these are the sorts of things that we're talking about, but actually getting systems, both at a county, city level, county level, and a national level, being able to address that's really difficult, and we fail and fail and fail again. But Julian Tudor-Hart reminds us that we have to try and achieve addressing the inverse care law. And that's why we work with marginalised groups. That's why we are passionate about working with the poorest and the most vulnerable. So, what's the difference between equality and equity? Just have a look at the picture for a minute and work it out.
Yeah, it'd be brilliant if anyone's feeling brave to try and just describe what they think they see.
So on the left, everyone gets a box, that's equal, but unfortunately, the person who's shortest needs more boxes. So that isn't really equality. Equity is making sure that the person that needs the resource gets it. Yeah? I love that. I like to think they're watching England playing cricket, but I'm not sure. In Antigua at the moment, batting very well at last. So, deprivation. Do you want to talk to this one, Marina, or shall I?
Yeah, so again, we weren't sure who'd be in the room, so we wanted to just summarise a bit about what we're talking about, so inequity and inequality. Are you guys happy with that concept before we move on? Just around that, yeah. So just to talk a little bit about deprivation. So the reason why deprived populations often have, there's these wide health inequalities between sort of less and more deprived areas, generally fall down to these kind of three big categories of reasons. So you've got public health issues, so there's higher obesity, smoking, alcohol-related diseases. We call those kind of health behaviours, so sort of negative health behaviours. There's often multi-morbidity, so people have much more complex health needs. So often this is called trimorbidity and kind of homeless healthcare. So substance use disorders, as well as mental health and physical health problems. And then it's about the living conditions. So they often live in overcrowded and unsuitable housing that can make them very vulnerable to poor health.
And then you add in that things like school performance, how good local schools are, what the availability is. You look at things like air quality, those sorts of things. Yeah, they're key determinants of health. There are lots of barriers to accessing the NHS. There are lots of barriers to accessing social care. My main role at the moment is working for a charity called Framework Housing Association in Nottingham, and I'm a substance misuse specialist GP for Framework. Framework and the third sector are passionate about trying to address these kind of barriers, the things that our patients find really difficult. So at the moment on our unit, I'm looking after Jack. It's not his real name, confidential, but we've worked out he's got an intellectual disability. He cannot work out when his appointments are. He can't really know which treatment I'm offering after he leaves the unit for an alcohol disorder will be best for him. He needs reminding to take his medication, to collect it from the chemist. He misses all of his outpatient appointments. He hates going on trains and buses. And that patient, Jack, describes the literacy, the administrative barriers, the understanding, the communication, the problems with substances. He lives in really grotty accommodation with a drug dealer in the room above him. It's massively affected his mental health. He finds it hard to travel. Fortunately, he hasn't really been wrapped up in much violence, though he has a few beers, he can fight, but he's never been imprisoned, and he lives in poverty. So that's someone, because he's grown up in the same village all of his life, but because of the set of cards he's been given, he is massively disadvantaged. And our role as the advocate, as the physician, as the healer, as the doctor, as the GP, is to help him navigate this journey to a better health outcome and find out how we can support him in maintaining improved health.
Yeah, so exactly. So what we were saying is on the last slide, that was again, when we think about the individual and the sort of system levels. So on the individual level, that was thinking about why, what's impacting that person's health on the previous slide with the deprivation, so their multimorbidity, their living environment, stuff like that, their social support network. But then this is more thinking about we need to acknowledge the problems in our system as well, and that is our role as a doctor, to really reflect on how we're providing healthcare.
I'm going to briefly give you another case now. In my practice in Beechdale in Nottingham, we look after a house of Eritrean asylum seekers, refugee patients who are pregnant, and it's wonderful that they come from Eritrea, war-torn country, in whatever stage of pregnancy they're at, and have their children in Nottingham. Their accommodation is still pretty challenging. They have massive barriers to face in terms of language, in terms of poverty. For me as their GP, it's actually, some of it's quite tough medicine. So one of the women had a baby fairly recently, and that baby had congenital rickets, neonatal rickets. I have never seen or treated congenital rickets in my 33-year medical career. I had to learn about it. I had to work out what the right treatment was, whether we should have given her some vitamin D in pregnancy, liaise with the midwives, the obstetricians, the paediatricians. New learning, lifelong learning, which we'll come to. But again, a wonderful example of barriers and networks, but how we can actually do good as doctors to address those things.
And just how important it is that over time that we keep on reflecting. So we've just gone through, we're still kind of amidst the pandemic. That's thrown out a whole load of healthcare access issues and increased domestic violence, increased substance use, increased child abuse, stuff like this. We all need to be thinking about. So it's constantly reassessing as a doctor how we're delivering care and not just providing in those consultation rooms perfect care.
We'll keep going because we'd love to take some questions. I think we've probably got about 10 slides
left. So as we've
left.
said, inclusion health here is just all about preventing and redressing health and social inequities among vulnerable and marginalised people. So
we want you to think about the populations that we're talking about, and forgive us if we use any words that aren't politically correct or that challenge you. It's not intentional, but we will show you the different groups that we're thinking about. I specialise in prisons and secure hospitals, what used to be called the criminally insane, so mentally disordered offenders, drug and alcohol users. Marina's passionate about asylum seekers and refugee populations. So it's lovely that you have us coming together, the old and the new, with different portfolios and aspirations within excluded groups. So let's show you some of them, shall we? And just let you think about them as they come up. And these are people who we know, and it's recognised, face real challenges, are excluded from what we would see as mainstream healthcare. Not all of them, not everyone, but generally as populations. And we don't really like naming, we don't want to stigmatise, but it's well recognised. For example, our Roma population in Nottingham has a really high incidence of pregnancy under the age of 18. So our teenage pregnancy task force, which I sat on for many years, our highest group are the Roma. And then we've got to think, how can we help that group? How can we access them and help them to access us, for example?
And also just recognise there are new groups coming up all the time. There are always, now in our world, people are moving and things are changing, society's changing. We're having different stresses like pandemics. There are increasing and shrinking different vulnerable groups. So it's always reassessing your population as a doctor and thinking about the needs in your community.
So we've got 85,000 prisoners locked up in the UK, and the churn through our prisons is about 250,000 a year. I love working in prisons and helping patients in prison. And what I find is the populations I look after have the worst health problems I've ever seen. And that's actually really exciting. Health conditions that you wouldn't really imagine seeing and dealing with, you get to see in these groups, which is really actually very exciting. You know, you feel like you're doing as much good as you can with the patients that really need it. And that's brilliant.
So I think a lot of you here have kind of got a mixed stage of careers, so we thought it might be interesting just to chat a little bit about what I've done and what Marcus has done, just to give an idea of a flavour of what kind of a career in inclusion health might look like. So I split my medical training in between two very different places. So I went to St Andrews, which is a small town in Scotland, and then I went to Manchester. As a medical student, I felt very disengaged in St Andrews. I didn't associate with why I'd signed up to be a doctor with the book learning side of things. And it was only when I went to Manchester and had the opportunity to sign up to one of these elective modules. So whilst you're at university, they often give you an opportunity during med school to choose something that you're interested in. So I signed up to, and the first year it was running actually, the Deprivation, Medicine and Health and Social Care module that provided a really fantastic opportunity for weekly teaching about inclusion health. And then it also placed you in a deprived area within a GP, and also gave you opportunity to choose a sort of third sector, so a charity organisation where you could directly work with a vulnerable population that you were interested in helping. So I split my time between Oldham, which you can see on the left. So I was in a lovely surgery called Hilltop Surgery, which was all associated with the above organisations who are just absolutely incredible. If you're ever looking for work in Greater Manchester, they're absolutely brilliant. And I also worked in a refugee centre here on the right. And through this, I kind of developed, first of all, an interest in community-based research. So getting to know my population, I looked at why are DNA rates, so did not attend rates for secondary care, so poor in deprived areas. So I went out, I visited people's homes, I saw barred up letterboxes from domestic violence victims, things I'd never thought about before, not getting letters, people who couldn't read, couldn't use phones, that all the simple things that kind of we rely on for getting people into their appointments. So I kind of started doing research, I started exploring what my population was in the refugee centre. I met lots of doctors who were retraining, so I initially sort of responded to that need and did quite a lot of communication skills and used my medical my knowledge as a medical student to help them. And then throughout the years I realised that actually something we could do that was really effective. I kind of started doing community-based medical education, and I worked with some fantastic mentors and students, and we started running voluntary schemes, putting students into these organisations to provide sort of advice about healthcare access and to provide a friendly face for the NHS. So refugees, migrants who are coming over there, our health system is made deliberately hostile, very difficult to, if you don't know how to use it, can feel quite complex. So we helped with things like GP registration, explaining rights to interpretation, filling out sort of healthcare entitlement forms, stuff like that. and we sort of educated people who worked with refugees and asylum seekers about healthcare entitlements, and also educated more students. And now I do that, I've carried that on into my practice as a junior doctor, teaching in my hospital, and working with very national sort of advocacy groups around healthcare entitlements and how important it is that we make sure that everyone knows their rights, and we try and fight against stuff that makes it more difficult to access healthcare, like stuff like charging for certain services that goes on for stuff like refugees and asylum seekers. So that's kind of where I've come to. So I developed this real love for community-based research and community-based medical education, and I saw the real value that general practitioners could make by engaging their community and responding to needs, and also the power of students. And that's why I've sort of specialising in medical education, because I think we're a really underused resource, medical students. And for me, I nearly sort of lost love with medicine, and what it re-engaged me was actually being able to use my skills and make a difference again, which often in 6 years, 5 years of training, you kind of lose that opportunity until you practice again. Okay. Marcus?
Yeah, I never imagined that I'd be here reflecting on my career like this with someone with so much energy and enthusiasm. It's fantastic. At our lovely college, it's just great to be here. But essentially, in 1986, we do an intercalated degree course in medicine in Nottingham. So I went round and I interviewed 90 GPs in their surgeries about their attitudes to alcohol harm reduction. And I think and prevention, I think that's where it all started. And I realised I was interested in addiction, but I loved general practice. I did plenty of psychiatry training, and then I ended up in a GP practice as a trainee on my own on a Friday morning, looking after the homeless and the rough sleepers in a night shelter, so lots of drug users. And it's just been an absolute privilege to see how drug and alcohol treatment services have evolved across 5 decades, from the 80s now to the 20s. I then chose to be a salaried GP in drop-in centres in Nottingham. Base 51 was for 12 to 25-year-olds, and the Friary drop-in in Leafy, West Bridgford, was for older populations. And then I started working in low secure hospitals, people who are mentally disordered offenders, who are locked up but they're not in prison. And they're wonderful places to work, because you get to practice your primary care skills of treating diabetes and infections and heart disease and high blood pressures with really interesting mental health presentations. So I loved that. And then my first prison gig was HMP Nottingham in '99. And that's a whole nother story to tell you. You have to perhaps tune into some of my lectures on substance misuse in secure environments through the college to hear some of the prison stories, but they're unbelievable. They are remarkable, and it's been a privilege to work with offender populations. As your career evolves, you're asked to do new things, and I became more political and started working with the BMA and the Royal College, and started to chair groups and sit on groups trying to prevent prisoners from killing themselves, trying to improve the conditions of GPs working in prisons, trying to bring our learning and our education together. So not only the advocate for the individual patient, but the advocate for the whole system. And it's still an absolute privilege to work with colleagues at NHS England and the Ministry of Justice and Public Health England, as it used to be called now, the Health Security Agency, to try and make things better. So I'm currently the chair of the British Medical Association's Forensic and Secure Environments Committee. But I have to level with you, I retired as senior partner in my practice in 2019, just pre-COVID. I'd had a bit of an annus horribilis, lost both parents, not really enjoying general practice like I used to, lost my mojo. We've been through COVID, and I'm now having a fantastic time again. So it's lovely to be able to be here and tell you about it. And I'm working with Framework doing inpatient drugs and alcohol. Patients from the whole of the southeast of England and the East Midlands coming to us for specialist treatment, which is brilliant. I left 2022 blank because as an OAP GP, you're always thinking about retirement. You're always wondering when you'll retire, how you retire, what's going to happen. So it's lovely to be with cross-generational colleagues and to have that bigger picture and that perspective of your professional journey. That's why I left 2022 blank. That's my nearest prison, HMP Dartmoor, built in 1809 for the prisoners, French prisoners from the Napoleonic Wars. I've put that there because I'm from Plymouth originally, and that's the closest jail. And I teach in these prisons now nationally, which is fantastic. So I've been in, 20 or 30 secure hospitals and prisons to treat patients and teach. And these are some of the other things that are relevant to me, but you don't need to know any more about that. Let's keep going.
Yeah,
we need some questions. So
absolutely.
We're nearly there.
Yeah, just drawing on what they were saying this morning as well, is for me, I've just sort of put my whole development of my interests and all the opportunities I've had have been through meeting fantastic leaders. So I think it's really going out there with an open mind and trying to meet your people. And I think that's what inclusion healthcare is wonderful. I mean, we immediately get on because we share interests and people want to help, because that's the kind of environment. It's a very creative.
We didn't know each other a week ago, which is just wonderful. Now we've got 2 more minutes and about 4 more slides. We're just going to whiz through them.
A bit longer because we started late. But
oh, do we get a bonus? Are we okay?
So,
a few minutes extra. Thank you.
I think we could probably have covered this, really.
Well, these are key concepts. Think about, if you're at the beginning, think about your career journey and let it evolve. Don't be too worried about it, I think. My daughter is a 29-year-old psychiatry trainee in Leeds. I wanted to enjoy it. But also, as an older doctor, remember it's lifelong learning. I'm learning new stuff from my patients. Had a patient came in 3 days ago from Hull taking DMT, dimethyltryptamine, a hallucinogen that we hardly ever see, that put him in hospital. He was so ill. And I'm learning about DMT. Wow. So your career journey, enjoy it, but remember it's lifelong learning, and be proud of that and embrace learning. It's, I think, a key to staying happy in your career. What's next? That's the one. How does that make you feel? Let's just pause for 10 seconds. What does that mean to you as a person, or as a doctor, or an aspiring doctor? It's very powerful, isn't it? And that's happening. And the fact that Marina practices in Brighton, that's on her doorstep. It's on our doorstep. How do we help these people? How do we address this inequality? What have those people been through? Who have they lost? Who's drowned in the Channel trying to get there? What was it like in Calais for a year? What was the exploitation, the abuse? Why is this happening? It's going to carry on happening, as we can see. When you see our last slide, you'll understand another perspective on this, whether it's Syria, Afghanistan, Iraq, Ukraine.
I think for sort of inclusion health and deprivation medicine, they often use the metaphor of kind of surfing and riding this wave of potential chaos and potential sort of all the great difficulties that these people could face. And so I found this picture very powerful, just as a sort of real life reflection of that, of a vulnerable population that we work with. So it's just thinking about how do we help those people, how do we guide them safely so that they can live.
And there are jingoists in this country who don't think we should help these people, and you have to remember that and be aware and sensitive to the political complexities, the Brexit kind of issues that these sorts of images promote in some people.
So we want to talk a little bit about professional challenges. So again, this is the classic image of people sort of doing hurdles and all the problems that not only sort of it's used for patients and what they face, like our patient populations, but also what a career in inclusion health can be like. This was actually from an article that Marcus directed me to based on somewhere he works at the moment, where it's sort of running inpatient detox services. And I just thought it summed it up really well, which is, as a student myself watching inclusion health sort of talks, this is what I thought, what amazing people, but
I'm going to read it out, Marina, because this is just last week in the BMJ Doctor magazine. Pete Blackburn, I invited him up, and he wrote up what he saw at our inpatient 20-bedded unit. But surely it cannot be the case that the provision of crucial services is so reliant on personal relationships, third sector organisations, and the individual drive of particular staff. It's great that we have those qualities, but the NHS, our health and social care system, which is funded out of our taxes, should be better than this. This should be available to all. It should be ubiquitous, not a rarity.
Yeah, so just like we were talking this morning, it's hard, and they're hard careers, and I have endless respect for doctors that I've seen working and who've had years of working in this area, because just common to every area of medicine, but again, inclusion health has is a very difficult area to work in for the same reasons, and hopefully that will change as there's more of a focus on social funding and the world's recognising it after COVID and the sort of spotlight on inequalities that's brought.
And to help us, the great work of Claire Gerardo and colleagues around practitioner health in helping us stay mentally well and on top of our portfolio as doctors when we're working with hugely disadvantaged populations and seeing really tough stuff is very important, and we should be very thankful for that. This is one of our patients from a couple of weeks ago in the doctor doing really well, about 8 days into, we'll call him Simon, 8 days into his alcohol detox.
And again, just we don't need to labour this, but we just threw around some rewards, and I think it's really important again to acknowledge that although this is for the greater good, it's also academically a really interesting and rewarding career. You can make really fantastic change quite quickly. It's a very responsive, sort of innovative area.
We brainstormed what we get out of our careers working with marginalised and disadvantaged groups, and agreed all of those things are really up there. Now, how does that sound as a career? You get paid to look after the poorest people, you learn exciting and interesting stuff, you work with great colleagues. Patients really appreciate that you want to help, that you're their advocate, that you can talk to them. I hope we've sold it to you.
And for me, as a foundation doctor staying in hospital, this is the stuff I really miss. And it's really made me appreciate it and feel really excited again to go into training. So it's something that you guys will work out, hopefully, for yourselves with your training. This is just some kind of organisations and resources, a few that I could think of that if you want to read a bit more, have fantastic work. You want to take a picture of it. And then, yeah, we just wanted to finish, obviously, on a Ukrainian flag, similarly to the lovely tribute this morning, and just open up if anyone's got any questions.
So thank you so much for that talk. That was really inspiring. I'm Olivia, I'm a medical student, and I was really interested to hear that, Marina, you had a module at university about deprivation medicine, because what I found is any kind of work that we've been able to do, volunteering with local vulnerable communities, has been just kind of through our own kind of like passion to help these people, and there's been no part in the curriculum to, even when we have communication sessions or things about ethics, we don't really speak about any of those vulnerable communities. And I just wanted to hear from you both actually how you found trying to help these people maybe with no frameworks in place, or how you found that module, and maybe something that I can bring back to my university and try and get them more on board.
Yeah, so Olivia, that's great that you've raised that, because that's my area of academic interest. So my desire is I'm researching and looking into curriculums, and there's so little opportunity really to do stuff, what they call community engaged medical education. So you do a lot of community-based, or you go in, you speak to somebody, or they come in and they tell you their real-life experience, or they highlight these sort of health inequalities and issues, but you don't really get much supported opportunity to go in and do something useful for your community, use your skills as a student doing that, and also benefit the community by responding to something that could be helpful. And that's what this new niche called community engaged medical education, that's really up and coming. So there's been a massive focus, particularly after COVID, on, and a pressure put on medical schools to actually start responding more to their community and to really use that potential workforce to help their communities. So places like Imperial College are doing a lot of research on it, and there's more and more popping up. But I think I totally agree with you, is that it was something that I had to do during med school because I felt very uninspired, and it reminded me why I was doing it, and I felt that I wasn't utilising my skills unless I was doing that, and then I could kind of see why I could make sense of why I was staying through this quite difficult process of medical training. But it was extra, and it meant that you do have to make sacrifices, and I think that's wrong. And my interest is, I think that you should have, all medical students should have some kind of community placement. I believe very strongly we have a responsibility for our communities. They give up our time as patients to teach us in hospital, and I think that we should be thinking about how can we give back as students, because it's not just giving, you're learning, you're using your communication skills, you're engaging with communities in their own environment when they're well. You're sort of building those kind of relationships and seeing people so you can ultimately provide much better holistic healthcare by understanding populations. I think you're onto something really interesting there, and that's kind of what I'm interested in.
You've got to ask for it, and you've got to seek it out. So you've got to ask for it from your union, from your peers, from your tutors, from your deans and sub-deans. Where is it? Why isn't it? How do we do it? But you've also then got to actively seek it out in the placements that you get. You need to challenge, I want to be able to do this module in this setting, please. Yeah, I don't want to do that bit of psychiatry. I want to do this bit. I want to be in a GP practice that's in the inner city where the poverty is. I don't want to be in a country village where the property is.
I also think people don't recognise the flexibility in placement sometimes. Sometimes it's worth seeing what your GP does. Often they're affiliated, they have community groups, they have some kind of in their grounds, or they might have like an allotment or a garden. It's just being a bit more creative, and when you're on a placement, recognising you don't have to, you can kind of ask them and say your interest and see if there's any scope or anyone they can
But
put
the
you in
system is
contact
so
with.
rigid, it's appalling, and that has to be challenged. So my daughter, during COVID, she lost her 4 months of psychiatry and had to do 8 months of surgery. But one of the colleagues didn't want to do psychiatry, wanted to swap, and they wouldn't let her. It's just ridiculous. Why is it so rigid and bureaucratic? And the NHS and academia gets more rigid and more bureaucratic, which as an oldie is quite frustrating.
Yeah, I think you're bang on that Marcus has got it, is that it's all about kind of, they wanted to hear from us. So when we did that module, we had to write feedback, we had to show, we presented, make sure you get into conferences, they can publish your research, they can publish where your abstracts, and the universities can promote it. So it's kind of practical tips as well of trying to get seen from what is sort of recognised, so stuff like getting abstracts out and stuff like that. Well, thank you all for listening. It's been an absolute honour to be here.
Thank you very much.
Thank you.
Thank you.